Good evening, participants. Thank you for joining Shield Connect. And today, the topic of webinar is Recurrent Pregnancy Loss, Newer Guidelines Simplified. And the speaker for the day is Dr. Sushma Meda. So before we go, let me give a little idea about our page Shield Connect. So let me share my screen. So this is our page shieldconnect.in, where you can connect and you can see various sections are available. So the first section is the blog section, where you can find all the blogs written by the eminent speakers and doctors. Then there is the second section, webinar, where you can see all the webinars, upcoming webinars. And then the second is the past webinars, where you can find all the webinars that we have conducted on Shield Connect. Then when you click on current webinar flow, then you will able to see this box where you can find our webinar, and there is the comment section. So participants, you can post your feedback and queries in this comment section. So at the end, we can have a interactive Q&A session with our speaker for the day. And there is the awareness page. There are 3 awareness page. First is the immune booster page, where we have reintroduced Sudocrem as a respiratory immune booster, and you can find all the blogs and video related to it. Then the second awareness page is PCOS awareness page, where you can see various topics related to PCOS by different doctors in different languages like Tamil, Hindi, English, Malayalam. Then the third page is the COVID-19 coronavirus awareness page. You can find all the blogs and videos related to COVID. Then we have a special page where you can see various days are available: Hypertension Day, Mother's Day, Safe Motherhood Day, GDM Special Day, Women's Day. So when you click on any special day like Hypertension Day, so you will able to get videos related to hypertension disorders in the pregnancy and various complications related to it. So this is the page Shield Connect. And now let me give a introduction of our speaker for the day, Dr. Sushma Meda. Ma'am has done MS in obstetric and gynecology. Ma'am is consultant obstetrician and gynecologist. Ma'am is certified by Fetal Medicine Foundation, FFM, in UK for anti-scan, TIFA, fetal echo, Dopplers. And ma'am is consultant in Sri Krishna Nursing Home in Nakerakal, Nalgonda, Telangana. So, ma'am, I welcome you on our platform, and I will give you the platform. We are glad to have you on our platform today. Thank you.
Good evening, everyone. Am I audible?
Yes, ma'am.
Okay. Please give a moment before I share my screen. Can you see my screen?
Yes, ma'am. We can see.
Okay. Today, my topic is recurrent pregnancy loss and what's new. So as we all know, recurrent pregnancy loss, 50% of the cases are idiopathic. So today I'm going to discuss on those idiopathic cases, which with the newer definitions, the idiopathic cases have come down to minimum. So first I'll discuss the basics, then we'll move on to the newer guidelines. Recurrent pregnancy loss is defined traditionally as 3 or more consecutive miscarriages occurring before 24 weeks. So, Ashrae in 2017, it defined recurrent pregnancy loss as 2 or more pregnancy losses before 24 weeks of gestation. So earlier we used to evaluate only after three consecutive losses. But now with this newer guideline, we are evaluating after 2 losses, and they need not even be consecutive. So this is the definition by each of the societies: Ashrae in 2017, ASRM in 2013, and RCOG in 2011. Pregnancy, according to Ashrae, it is confirmed by urine or serum beta HCG. So only if beta HCG is positive, that is enough to consider it as a pregnancy loss when there is a loss. Whereas ASRM in 2013, it said that it should be a clinical pregnancy. That means it has to be documented either by ultrasound or histopathological examination, and it has excluded biochemical pregnancies. Whereas Ashrae in 2017, it even included biochemical pregnancies. What it excluded are ectopic and molar pregnancies. So because ectopic pregnancies have an altogether different pathology, they cannot be assessed according to recurrent pregnancy loss assessment. So weeks of gestation, it should be less than 24 weeks. And the number of recurrences, it should be either 2 according to Ashrae and SRM, but it is 3 according to RCOG. So now from 2011, from 3 pregnancy losses, we have moved on to 2 pregnancy losses in 2017. So it can be either consecutive or non-consecutive according to Ashrae. Because only if there are 3 consecutive pregnancy losses, we used to evaluate them according to this protocol. But now, even with 2 pregnancy losses, which cannot be consecutive, that means it can be interspersed with the normal pregnancies. Even then, we have to evaluate them if there are 2 pregnancy losses. So why is it important? Do we evaluate a single pregnancy loss, or do we evaluate a 2 pregnancy losses, or do we evaluate 3 pregnancy losses? Why is it important? Because when there is 1 pregnancy loss, that is when there is a sporadic pregnancy loss, we need not actually evaluate it, because most of them are genetic and most of them are aneuploidies, and they are not recurrent. They are non-recurrent, most of them. That's why we don't evaluate for a single pregnancy loss. Whereas when it is 2 pregnancy losses or 3 or even more pregnancy losses, these are usually recurrent causes. So even if the pregnancy loss is either 2 or 3, the causes are similar. The proportion of causes are similar. That's why we can start evaluating with 2 pregnancy losses. What are the types of RPL? They are primary, secondary, and tertiary. Primary is they never had a previous viable infant. In secondary, these losses are preceded by a viable pregnancy. In tertiary, they are interspersed with normal pregnancies. Multiple miscarriages are interspersed with normal pregnancies. That means they are non-consecutive. Incidence. So for a singleton miscarriage, for a sporadic miscarriage, it is the incidence varies between 15 to 30%. And when there is a single miscarriage, we don't usually evaluate unless there is an important cause to evaluate. So when there are 2 pregnancy losses, the incidence is 3 to 5% of all pregnancies end up in having 3 to 5% of all women have 2 pregnancy losses, and 1 to 2% of women have 3 pregnancy losses. So when there are 2 or more pregnancy losses, we start evaluating. What is the prevalence? The prevalence of miscarriage is higher with increasing maternal age. So this, we all of us know that with increasing maternal age, miscarriage increases. And smaller the gestational age, miscarriages are higher. That is, at smaller gestational age, like before 6 weeks, the miscarriage rate is like 20 to 57%. And between 6 to 10 weeks, it is 15%. And after 10 weeks, it is 2 to 3%. That is, whatever miscarriages can happen, they usually happen before 10 weeks of gestational age. So here, percentage of pregnancy losses by maternal age. We'll consider this one. So when we consider maternal age, till 34 years of age, the pregnancy losses is same, less than 15%. But once it crosses 35 years, it is 24%. After 40 years, it is as high as 50%. And after 45, it is like almost every pregnancy is going to miscarriage. Only 7% are going to end up in live pregnancies. So what are the risk factors for RPL? Maternal age, previous miscarriages, obesity, and environmental factors. With increasing maternal age, recurrent pregnancy loss increases. And with the number of previous miscarriages, the subsequent miscarriage risk increases. Like after one miscarriage, there is 20% for the second miscarriage. After 2 miscarriages, there is 30% risk. And after 3 miscarriages, the 4th pregnancy landing up in a miscarriage is 40%. Obesity, it increases risk of both sporadic and recurrent miscarriage. Environmental factors like cigarette smoking, caffeine, and alcohol consumption, they are also responsible. So when dealing with a couple with recurrent pregnancy loss, we have to deal with obesity and environmental factors. Both the couples, both the male and the female partners, should be advised on weight reduction and to give up smoking, caffeine, and alcohol. Etiology. So coming to etiology, as we all know, for sporadic miscarriages, most common etiology is genetic. Whereas in recurrent pregnancy loss, the miscarriages are shared, the proportion is endocrine, genetic, and anatomic and immune. All these factors contribute to recurrent pregnancy loss. But only in 50% the cause can be determined, whereas idiopathic is about 50%. But with the newer guidelines, even idiopathic has come down. Causes of recurrent pregnancy loss, idiopathic is 50%, genetic is 2 to 5, anatomic is 10 to 15, autoimmune is 15 to 20, infections are around 0.5 to 2, hormonal is, that is endocrinological causes, are 15 to 20%. So in genetic, we have balanced and unbalanced translocations and euploidies. In anatomic, we have both congenital Mullerian anomalies and acquired anomalies like fibroids, polyps, and Asherman syndrome. In autoimmune, most important is A+. In infections, here I would like to make a point that torch infections should not be done, torch testing should not be done in recurrent pregnancy loss evaluation, because torch infections do not cause recurrent pregnancy loss. They can only cause sporadic losses. And in hormonal evaluation, we have diabetes evaluation, PCOD, and luteal phase deficiencies, thyroid, and prolactin. We'll deal with each of them. First, genetic factors. I'd like to talk on balanced and unbalanced translocations, and also regarding microarray and karyotyping. So where do we see balanced and unbalanced translocation? Is it in parental karyotyping or in the products of conception? Which is seen in what? Balanced translocation is seen in parental karyotyping, whereas unbalanced translocation is seen in fetal karyotyping. So what is this translocation? All of us know that in meiosis, crossing over occurs. Crossing over occurs between homologous chromosomes. That is, if these two are chromosome 1, crossing over occurs between chromosome 1. And these two are chromosome 2, crossing over here occurs between homologous pair of chromosomes. But in case of balanced translocation, crossing over occurs between different chromosomes, between any of the different chromosomes. Here, for example, crossing over occurred between chromosome 1 and chromosome 2. So the resulting genotype will be a 46 genotype with all the chromosomes present. So this patient will not be having any genetic disease. But when this patient produces gametes, these gametes will be abnormal. So balanced translocation is seen in parents, and when these parents, one of the couple is having a balanced translocation, if that couple produces gamete, there will be either a normal or balanced gametes in 50% of the cases, or unbalanced gametes in the another 50% of the cases. So these unbalanced gametes results in miscarriages. So as you can see, this is seen in balanced translocation is seen in parents. These parents will not have any genetic disease because they have complete set of chromosome, though they are on the different chromosomes. So when this person is married to a genetically normal person, they can have either 50% chances that they have normal fetuses and 50% chances that they have fetuses with chromosomal anomalies, that is with unbalanced translocation, and they might result in miscarriage. So how do we detect? Is it by karyotyping or microarray? So first, this is a picture of a karyotyping. This karyotyping can be compared with library analogy. When there is in a library, when there are, for example, 1,000 books. So if like in karyotyping, we detect if all the books are present and if all of them are in order, that is, there is no inversion, there is no deletion. That is what we detect in karyotyping. Whereas in microarray, if in these 1,000 books, for example, in all the 1,000 books, there are like 1 million pages. In microarray, we detect if there are 1 million pages or not. So karyotyping only detects major anomalies, whereas microarrays can detect even smaller anomalies. So which is better, karyotyping or microarray? In karyotyping, cell culture is to be done. So it can detect only from dividing cells. For products of conception, it's not easy to get dividing cells in products of conception. Most of the times there is failure, and most of the times there is maternal contamination when you try to do karyotyping. So in products of conception, it is always better to do microarray. Whereas in parental karyotyping, we are only aiming mostly at balanced translocation. There we can consider karyotyping. The 2017 Ashrae guidelines issued a recommendation against routine use of product of conception karyotyping. So product of conception should not be karyotyped, but issued a strong recommendation in favor of using microarray whenever genetic analysis was performed in products of conception. So whenever we do products of conception, we should not be doing karyotyping, but instead we should be doing microarray. When do we evaluate for genetic factors apart from recurrent pregnancy losses? When you have anembryonic pregnancies, when there is history of malformations or mental retardation, and when there is advanced maternal age. So what do we have in parental chromosomal abnormalities? One of the partner carries a balanced structural chromosomal anomaly. So in parental karyotyping, we find balanced structural anomalies, if at all it is abnormal, I mean. In embryonic abnormalities, there are usually aneuploidies, and aneuploidies are mainly responsible for sporadic miscarriages. Whereas in recurrent miscarriages, you see unbalanced translocations. So how do you manage when the parents are diagnosed with genetic translocation? Genetic counseling, and we can offer them assisted reproductive technologies, including PGD. But according to recent guidelines, PGD is as good as no treatment at all. I mean, PGD is not giving any added advantage. Use of either donor oocyte or donor sperm, depending on the affected partner. This is 2014 guidelines of ACOG. How do we manage a miscarriage? When there is only one miscarriage, no action unless clinically indicated. When there are 2 consecutive miscarriages or 3 consecutive non-consecutive miscarriages, then we have to obtain fetal products of conception karyotyping. So actually, latest guidelines are microarray. This was way back in 2014. That's why they were still in karyotype. But latest guidelines, they advise products of conception microarray. So when the products of conception microarray is done, when there is a aneuploidy, then no further evaluation is recommended because that is not recurrent usually. Whereas when there is an unbalanced chromosomal translocation, then you have to offer couple karyotyping and offer PGD for future pregnancies. If there is euploid karyotype, then we have to go on with full recurrent pregnancy loss workup. So, according to Ashrae, parental karyotyping is not to be done on a routine basis, but analysis of pregnancy tissue, that is products of conception, for explanatory purposes using microarray. So, causes of recurrent pregnancy loss, we have covered genetic. Now we'll move on to anatomic factors which contribute to around 10 to 15%. So anatomic factors can be either acquired or congenital. Congenital contribute to 6 to 7% of recurrent pregnancy losses. In 2% of normal women, there is congenital anomalies. That is, in women without any recurrent pregnancy loss, 2% in the normal general population is the frequency of congenital uterine anomalies. Whereas in RPL, it is 6 to 7%. So pathogenesis, it is attributed to reduced intrauterine volume and poor vascular supply. In congenital and acquired causes, in congenital causes, we have septate, uniconjugate, didelphys, biconjugate, DES exposure, which is not seen now. In acquired, we have myomas, adhesions, polyps, and incompetent cervix. This is Ashrae classification of anatomic abnormalities, congenital anatomic abnormalities. This is a normal uterus, which is classified as class 0. Then this is dysmorphic uterus, which is U1, T-shaped and infantile. Septate uterus is classified as U2. Septate uterus also called as resorption defects. And in class 3, bicorporeal uterus, which are fusion defects. So earlier there was separate for biconjugate and didelphys. But according to recent Ashrae classification, both biconjugate and didelphys both are considered as single bicorporeal uterus because both of them are variable degrees of fusion defects. Septate uterus is a resorption defect. Hemiuterus is U4. Either uniconjugate uterus with rudimentary horn or without rudimentary horn. Aplastic uterus is U5. So now with the current available evidence, the most important treatment is for septate uterus, that is septal resection in women with recurrent pregnancy loss can be considered. Whereas for bicorporeal uterus, metroplasty cannot increase live birth rates. So metroplasty is not recommended according to available evidence. Only septal resection can be considered in women with recurrent pregnancy losses. And nothing can be done in case of uniconjugate uterus except for removal of this, but not for RPL. This is Ashrae classification. This is uterine classification, whereas there exists separate classification for cervical and vaginal, and we have separate numbering system. How do we assess a uterus? HSG cannot be used for evaluation because we cannot look at the outer contour. That's why we cannot differentiate septate and biconjugate or bicorporeal uteruses. Sonohysterography, it is more accurate than HSG. It can differentiate septate and biconjugate uterus. Whereas gold standard is combined hysteroscopy and laparoscopy. A regular transvaginal ultrasound, it can detect presence and location of other anomalies, but 3D ultrasound is preferred and recommended by the latest guidelines. 3D ultrasound is recommended. MRI is not done routinely. And it can be done when 3D is not available, is what the guidelines say. Now, unicornuate uterus. So there is no surgical procedure for unicornuate uterus, but available evidence suggests that most pregnancies are best managed expectantly with cervical cerclage reserved for those with previous second trimester losses or with cervical shortening on ultrasound. Septate uterus. This is the most common developmental anomaly. It has the poorest of outcomes among all the uterine congenital anomalies. The miscarriage rate is 65%. So mechanism is implantation on poorly vascularized septum. Uterus didelphys. In uterus didelphys, only surgery indicated is removal of an obstructing longitudinal vaginal septum. So if there is associated vaginal septum, it has to be removed, but nothing regarding the uterus. In biconjugate uterus also, metroplasty is not proven to have any advantage. In uterine leiomyomas, submucosal fibroids, because they distort the cavity, they are to be removed. Even uterine polyps also are to be removed. Intrauterine adhesions, which can cause because of excessive curettage, which damages the granulation tissue and the basalis layer. Here, because of insufficient endometrium, it does not support fetoplacental growth and it can lead to recurrent abortions or even infertility. So, in these cases, hysteroscopic removal can be done. Hysteroscopic removal and followed by approximately 4 weeks of high dose exogenous estrogen. Exogenous estrogen should be given continuously for 4 to even some authors advocate till 12 weeks continuous exogenous estrogen so that basalis layer is well developed. Next, cervical insufficiency. Women with, the guidelines says that for cervical insufficiency, women with history of second trimester pregnancy losses and suspected cervical weakness should be offered serial cervical sonographic surveillance. And in women with a singleton pregnancy and a history of recurrent second trimester losses attributable to cervical weakness, cerclage could be considered. So the causes of cervical insufficiency can be either congenital or acquired. So congenital, we all know that Mullerian tube defects can lead to cervical insufficiency in some scenarios, but we should also keep in mind that abnormal collagen tissue like Ehlers-Danlos and Marfan syndrome also can lead to cervical insufficiency. So when we detect a cervical insufficiency in a primate without any acquired causes and without any Mullerian defects, we should consider collagen tissue disorders. So acquired causes are because of damage to the cervix because of any procedure. So we have dealt with genetic and anatomic causes. Let's move on to hormonal causes. So endocrine factors that predispose to an increased risk of pregnancy loss include thyroid, diabetes, PCOD, and luteal phase deficiency. The current recommendations are thyroid stimulating hormone and thyroid peroxidase antibodies. They are recommended in women with recurrent pregnancy loss. So if TSH is more than 4, we have to treat it with L-troxin. Whereas if TSH is between 2.5 to 4, we have to do thyroid peroxidase antibody. And if it is positive, we have to treat. If it is less than 2.5, we need not treat. Like 2.5, we need not treat less than 2.5. 2.5 to 4, we have to treat only if TPO is positive. More than 4, we have to treat it. Next, assessment of polycystic ovary syndrome, fasting insulin and fasting glucose is not recommended in women with recurrent pregnancy losses to improve prognosis because it is not helping with prognosis. That's why it is not advised. Prolactin testing is also not recommended in women with RPL in the absence of clinical symptoms of hyperprolactinemia, that is oligomenorrhea and amenorrhea. That means only in women with clinical symptoms suspicious of hyperprolactinemia, in them it can be recommended, but not in every woman. So what are the Ashrae guidelines? TSH and TPO followed up by T4 testing in cases of abnormal screening results. If TSH or TPO are not abnormal, then we have to do even T4. So previous guidelines, RCOG did not mention even TSH testing, but that was very way back in 2011. Now, routinely we do for every single pregnant woman. ASRM, it advised screening for thyroid or prolactin abnormalities and also for HbA1c to diagnose diabetes. And what is the treatment options that Ashrae has recommended is, it has recommended levothyroxine for hypothyroidism. It has recommended vitamin D supplementation. Though vitamin D investigation is not advised, Ashrae recommends vitamin D supplementation to improve the general health of a woman. Next, if there is hyperprolactinemia, then bromocriptine is the drug of choice. Now, I think cabergoline we use routinely, and other treatments are not advised. ASRM, maternal endocrine disorder, should be treated is what it says, but not how and when. So these individual hypothyroidism, diabetes mellitus, and PCOD, I'll skip these slides. And luteal phase deficiency, this progesterone treatment in luteal phase deficiency is always controversial. Few studies say that progesterone has to be given, and few studies say that progesterone has no role. But dihydrogesterone is actually proven to be beneficial in recurrent pregnancy losses because of its immunological effects, because of its benefits in immunological modification. Now, other causes left are infections. So, as I said earlier, TORCH group of infections, TORCH testing should not be done for RPL. TORCH can cause only single sporadic infections, sporadic miscarriages. So these are all the infections that are contributed for sporadic miscarriage, but not for recurrent miscarriage. So as we all know, rubella, cytomegalovirus, toxoplasma, malaria, brucella, all these infections, bacterial vaginosis, all this can cause sporadic infection. So what are the bacteria that are implicated in recurrent pregnancy loss? They are chlamydia and ureaplasma ureolyticum. These are the two infections that can generate chronic infection and potentially recurrent pregnancy loss. So what is the treatment? Treatment is very simple. That is doxycycline 100 mg BD for 2 weeks. This can treat recurrent pregnancy loss caused because of infections. So next we'll move on to autoimmune causes. Immune factors. This antiphospholipid antibody syndrome, it is the most treatable cause of recurrent pregnancy loss, and it is evidence-based and widely accepted. Up to 15 to 20% of women with recurrent pregnancy loss have antiphospholipid antibodies. In 5% of APLA cases, second or third trimester losses can occur. Though third trimester losses, we don't include it under recurrent pregnancy loss. Recurrent pregnancy loss is only before 24 weeks as per the definition. So about 5 to 10% of all pregnancies are complicated by preeclampsia or fetal growth restriction, and up to 75% in preterm births with patients in APLA. So how do we diagnose? What is the diagnostic criteria? For APLA, clinical and laboratory criteria. Clinical criteria, we should at least have 1 clinical and 1 laboratory criteria. Clinical criteria of thrombosis, that is unrelated to pregnancy, there can be either arterial or venous thrombosis or small vessel thrombosis. There should be some evidence of past history of thrombosis. And in pregnancy, there can either be more, after 10 weeks, there can be 1 unexplained fetal death. Less than 10 weeks, there can be 3 unexplained abortions. And less than 34 weeks, if there is a premature birth because of severe preeclampsia, because of IUGR, all these are the clinical criteria. And coming to laboratory criteria, anti-cardiolipin antibodies, IgG and IgM in high titers of more than 40, lupus anticoagulant if it is detected, and anti-beta-2 glycoprotein. So amongst all the three, lupus anticoagulant positive patients will have worst outcomes. And any two antibody positive or all the three antibody positive will have even worse outcomes. But if there is only one antibody positive and that is lupus anticoagulant positive, then these patients have worse outcomes compared to these two antibody positive patients. So this laboratory criteria should be positive on 2 or more occasions at least 12 weeks apart. Usually our patients don't turn up after 12 weeks for the second workup. So what is the value of thrombophilia screening in women with recurrent pregnancy loss? In thrombophilia, we have both hereditary and acquired thrombophilias. So the guidelines say that for women with recurrent pregnancy loss, it is not suggested to screen for hereditary thrombophilia unless in the context of research. Whereas it is recommended to screen for antiphospholipid antibodies like lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein. But there is some variation regarding beta-2 glycoprotein in the further newer guidelines, that they consider that beta-2 glycoprotein does not have much significant correlation to recurrent pregnancy loss. Instead, they are suggesting a new antibody, that is antiphosphatidyl antibody. I'll discuss about it in the subsequent slides. Antiphosphatidyl antibody. So Ashrae says thrombophilia, we don't have to, that is hereditary thrombophilia, there is insufficient evidence. That means protein C, protein S, anti-nuclear antibodies, all those are not advised. Whereas immunology, antiphospholipid antibody syndrome, for this treatment is advised, that is low dose aspirin starting before conception. This is important. We have to start before preconceptionally, at least 3 months before conception, low dose aspirin. And once urine pregnancy test is positive, we have to add unfractionated heparin or low molecular weight heparin. Low molecular weight heparin is preferred. So this at positive pregnancy test is very important, because earlier guidelines used to say that we have to start low molecular weight heparin only after heartbeat is seen on ultrasound. But newer guidelines say that we should start as soon as positive pregnancy test. Whereas for thrombophilias, there is no treatment. I mean, with or without treatment, the pregnancy cannot be changed. In inherited thrombophilia, no screening is required unless in context of research. And hyperhomocystinemia is not routinely recommended. So all these factor V Leiden, factor 2, protein C, protein S, antithrombin, homocysteine, all these investigations are not recommended. So now that we have covered all the causes, now we'll move on to idiopathic. So is the idiopathic still 50%? So this is a new paper that is published in October 2020, and they have dealt with 1,350 cases of recurrent pregnancy loss patients. So that is a huge number, 1,350 cases of recurrent pregnancy loss cases they have dealt with, and they have evaluated, diagnosed, and managed. And according to this paper, that is a new algorithm for the evaluation of recurrent pregnancy loss redefining unexplained miscarriage. So according to this paper, unexplained miscarriage is limited to less than 10%. So the key points in this paper is that couples with 2 or more pregnancy losses should be evaluated, and an evaluation including cytomicroarray on products of conception should be done, and along with modified American Society for Reproductive Medicine workup. That is all the other investigations that we have seen till now. And with all these, about 90% of the couples they could provide a explanation. So this is a very new thing, because even ACOG or Ashrae haven't come up with 90% detection, identification of cause for recurrent pregnancy loss. But in this paper, these people have used all the guidelines. So let me explain what they are. In unexplained miscarriage, will be reduced to approximately 10%. So idiopathic is no longer 50%, but it is only 10%. So what is the other 40% that we have always thought as idiopathic, that now they have found the cause is genetic, because they have started using cytomicroarray, chromosomal microarray instead of karyotyping. They could find so many anomalies that could not be detected earlier with the traditional karyotyping of products of conception. So knowing the causes of miscarriage often provides great psychological and emotional relief, as patients often put the responsibility for the loss on themselves. So what is this proposed guidelines that are released in 2020 by this paper is, parental karyotyping is not recommended unless products of conception chromosomal array reveals unbalanced translocation. So according to them, parental karyotyping is only recommended if there is unbalanced translocation on the products of conception. And in products of conception cytogenetic analysis, they recommend using chromosomal microarray for the second and subsequent pregnancy losses. Uterine anatomy evaluation is recommended by 3D ultrasound. Antiphospholipid antibodies, yes, it is recommended, but as I told earlier, we have to evaluate lupus anticoagulant, anticardiolipin antibodies, and here this is not beta-2 glycoprotein, but it is antiphosphatidylserine antibodies. What they suggest is that beta-2 glycoprotein positive patients do not have, it is not related to recurrent pregnancy loss, whereas this one, antiphosphatidylserine antibodies, if they are positive, these patients have significant pregnancy losses. And thyroid function, it is recommended, of course, TSH, and TPO should be done when TSH is more than 2.5. Prolactin also, these people are recommending. Actually, Ashrae, it recommended prolactin only under a condition, that is, if there are clinical signs of hyperprolactinemia, like oligo or amenorrhea. But these paper, they advise prolactin for everybody. And HbA1c, it is recommended, whereas it was not recommended by Ashrae. So what are the changes they have made? And what are the investigations that they recommend? POC, parental karyotyping is not recommended as a first line, whereas products of conception cytochromosomal microarray is the first line investigation, and 3D ultrasound is the first line investigation. APLAS is first line investigation with a small change, that is, instead of beta-2 glycoprotein, we have antiphosphatidylserine. Then in endocrine evaluation, we have TSH and TPO when TSH is high, then prolactin and HbA1c. So, and other investigations are, for hereditary thrombophilia, it is only recommended if a personal or strong family history of thrombosis. That is, if the patient or in the family there is a history of thrombosis, only then hereditary thrombophilia is recommended. So it is not a first line. Sperm DNA fragmentation, which is gaining importance nowadays in the evaluation of recurrent pregnancy loss, is not actually recommended. PCOS evaluation, luteal phase insufficiency evaluation, ovarian reserve testing evaluation, all these are not recommended, but they recommend to supplement vitamin D, because to improve the general health, and vitamin D deficiency is known to cause recurrent pregnancy loss. So this is the flow chart that they have shown, that they have given to diagnose about 90% of cases of recurrent pregnancy loss. I have cropped it into smaller slides. So this is the first box. These are the first line investigations. What they say is, for a first trimester loss after second miscarriage, the workup includes Screen for weight extremes, alcohol, smoking. So as we already discussed, lifestyle modification, especially obesity and alcohol and smoking, all these are important risk factors for recurrent pregnancy loss. Then cavity check is by 3D ultrasound. 3D ultrasound to rule out uterine anatomic abnormalities, either congenital or acquired, can be diagnosed by 3D ultrasound. And this is more recommended. This is recommended instead of hysteroscopy and laparoscopy because this is a non-invasive technique. And antiphospholipid antibody should be tested by lupus anticoagulant, antiphosphatidylserine, and anticardiolipin IgG and IgM. So endocrine testing is TSH, TPO, prolactin, and hemoglobin A1C. Whereas PCOD, luteal phase deficiency, all those investigations are not advised. Then if you find any of these abnormalities, then manage abnormalities accordingly. Also consider prophylactic vitamin D supplementation for all and provide psychological support. So all these are on par with ASRM guidelines. But additionally, they have introduced product of conception cytogenetic analysis as a mandatory investigation in the evaluation of recurrent pregnancy loss. So when they added this, Ashrae has advised this as an optional investigation. But these guidelines, these people have recommended that products of conception chromosomal microarray should be definitely included. So what are the results after products of conception? If it is euploid, if it is aneuploid, and if you detect unbalanced translocation, how do we further evaluate? In products of conception microarray, if it is euploid, so then you have to detect other anomalies that are considered in 1, 2, 3, and 4, that is abnormal cavity or endocrines or antiphospholipid syndromes. If there is anything detected, then that has to be treated. If nothing is detected, then you have to go to the second set of investigations. If it is not euploid, if it is aneuploid, then no further testing is advised and expectant management, because aneuploid are non-recurrent usually. And in unbalanced translocations, do a parental karyotype. And if there is a balanced translocation found in any of the patient, give genetic counseling, consider PGT-SR versus expectant management. So this is important because pre-implantation genetic testing is not superior to expectant management, is what the current guidelines say. This is one of the options that we can offer to the couples, but we should also tell them that it is not foolproof. So what do you do when it is euploid and when all the other investigations are so far that we have done are normal? These patients are come under unexplained cases, and these are less than 10% among the 1300 patients they have evaluated. So unexplained cases, for them, we have to do further evaluation. These are the second line investigations. These include hereditary thrombophilia testing, sperm DNA fragmentation testing, parental karyotyping, luteal phase deficiency testing, chronic endometritis testing, and if there is previous history of uterine surgery, you can even consider hysteroscopy. So all these are only second line investigations. Only by doing first line investigations, they were able to detect a cause in about 90%. So, and this is the continuation, box 3. So what after third miscarriage, what do we do? If there is no testing has been done so far, like if they are not evaluated after a second miscarriage, then we have to investigate and manage according to above algorithm. So if above algorithm has been followed already in previous miscarriage, then again we have to repeat products of conception chromosomal testing by microarray and complete the full workup if not already done. Full workup is second step. So if all possible known etiologies have been addressed and product of conception aneuploidy is repetitive, consider expectant management versus PGTA. So when aneuploidy is there and it is repetitive, then we have to consider options of expectant management versus PGTA. So this is the sum up of all the slides. In the first line investigations, we have reducing weight and alcohol and smoking, avoiding it. Then cavity check, anatomical causes by ultrasound, screening for antiphospholipid antibody, and endocrine testing, that is TPO, prolactin, and HbA1c. And cytogenetic analysis by chromosomal microarray of products of conception. These are the first line investigations, and this is the sum up of my whole talk today. Thank you.
Thank you so much, ma'am, for giving all the newer guidelines related to this topic, recurrent pregnancy loss. So let me check if we have any queries in the comment section. 1 minute. So, ma'am, the first question is whether anti-nuclear antibodies testing is required in women with RPL situation?
No, anti-nuclear antibody testing is not recommended. Amongst the tests that are not recommended, anti-nuclear antibody is one of them. Ashrae specifically says that anti-nuclear antibody testing is not recommended.
Okay. Then the second question is there any effect of thyroid hormone imbalance on recurrent pregnancy loss?
Yes, thyroid hormone, usually we do thyroid evaluation even in first pregnancy loss. So thyroid pregnancy abnormality causing recurrent pregnancy loss is not routinely seen.
And what is your recommendation regarding vitamin D in such cases?
Vitamin D, you mean?
For vitamin D supplementation?
Yeah, vitamin D supplementation is recommended by Ashrae, and also according to the new paper that is published in 2020, vitamin D has to be given preconceptionally for 2 to 3 months is what they advise.
I cannot see any more questions.
2000 international units every day. Yeah. The dose is 2000 international units per day.
Thank you so much for giving all this information regarding this topic and providing all the newest update by the Ashrae on this topic. And we would like to have more sessions with you further. Thank you so much, ma'am.
Thank you so much, Shield Connect, and thank you all the audience for patient listening.